The first assessment that we'll be going over is the Orpington Prognostic Scale, which is an assessment that includes measures of motor deficit, specifically within the arm, proprioception, balance, and cognition. The OPS is based on an earlier prognostic tool, the Edinburgh Prognostic Score, but adds an assessment of cognitive dysfunction. The OPS scores range from 1.6 to 6.8, and higher scores indicate greater deficits. Deficits can be categorized as mild to moderate, which are scores below 3.2, moderate to moderately severe, which are scores 3.2 to 5.2, and then severe or major, which are scores above 5.2. The OPS measures within the ICF domain of body function. The populations tested are the stroke population, specifically adults ages from 18 to 64. The only equipment required for the OPS is paper and pencil for scoring. And then the time to administer the assessment is 5 minutes, with the cost of OPS being free. Special considerations for the OPS is that within the balance portion of the assessment, a patient can use an assisted device, but only for that portion. The OPS assessment has excellent test-retested reliability as well as excellent inter-rater reliability for chronic and acute stroke. For acute stroke only, the OPS has excellent concurrent validity as well as excellent predictive validity. However, there has been no ceiling or floor effects recorded for the OPS assessment. The OPS does have predictive qualities, as scores below 3.2 indicate a high likelihood of returning home. Scores that fall between 3.2 and 5.2 generally respond better to rehab, and patients with scores above 5.2 are typically dependent with an increased risk of being in an institution. Limitations of the OPS assessment is that it should not be used for an acute prognosis, and that the scale should only be used when the patient's neurological condition has been stabilized. However, optimal predictive power was observed within the OPS when administered 2 weeks post-stroke.
All right, so for the OPS here, I have the score sheet and the instructions. So the first part is motor deficit, which is within the arm. So what I'm gonna have is my patient Matt here is gonna be laying supine, so if I can get you to lay down. What I'm going to be doing is I'm gonna be lifting, or the patient flexes the shoulder up to 90, and I'm gonna be adding some resistance. So what I'm gonna do is hold your hand right there, and don't let me push you down, okay? All right, good. And so go ahead and lower your arm. All right, so then with that, depending on how he does, we score accordingly to the score sheet that was showed earlier in the video. So second now is proprioception. So now what we're gonna do is I'm gonna have you sit back up for me. And I'm gonna have the patient with their eyes closed and with the affected arm overhead by the therapist. So I'm gonna have it overhead by me. So go ahead and lower, and I'm gonna, perfect. So now what I'm going to instruct the patient is to locate their thumb by their opposite arm. So go ahead and see if you can touch your thumb for me. Perfect, and that will be scoring depending on how the patient does with the scoring again in the score sheet that was shown earlier in the video. So now we have the third is balance. So the patient may use an assistive device for this, and it can only be used for this portion only. So what we're gonna do is I'm gonna have my patient right here for me, if you could just stand. And he's gonna have an imaginary gait belt on, because we want safety. There, gait belt right here.
No, right there.
So what we're gonna do is we're gonna guard appropriately, and we're gonna walk 10 feet and see how he does, okay? So we're just gonna kind of guesstimate here. What I want you to do is walk from here to the other side.
Okay.
Perfect. All right, and then we would score appropriately within the score sheet. Now, fourth is cognition. So I'll just have that seat right here. So we're gonna have one score for each point that they answer correctly within this cognition. So first is the age of the patient, so can you please tell me your age?
34.
Perfect. And can you please tell me what time it is? And this is to the nearest hour.
About 2.
Perfect.
Okay.
All right, so now I'm gonna give you just kind of an address, and I want you to please remember it, okay, towards the end. So I'm gonna give you 2592 East Sweetbriar Drive. All right, can you repeat it after me?
2592 East Sweetbriar Drive?
Yes, perfect.
Okay.
All right, and then can you tell me the name of the facility that we're in?
UAMS.
Perfect. Can you tell me the year?
2018.
Awesome. Can you tell me the date of birth of you?
July 8th, 1984.
Perfect. Can you tell me the month?
It is September.
Awesome. And can you tell me the name of the president?
Trump. Donald Trump.
Awesome. And then can you count backwards from 20 to 1?
20, 19, 18, 17, 16, 15, 14, 13, 12, 11, 10, 9, 8, 7, 6, 5, 4, 3, 2, 1.
Perfect. And now can you tell me the address that I asked you to remember?
2592 East Sweetbriar Street.
Drive.
One of those
But
things.
close enough. Perfect.
All right.
All right. So having all that, you score, and then you see where they're at kind of on the predictive scale within the score sheet.
All right, today I'm going to be talking about the functional independence measure. This is a uniform system of measurement for disability based on the International Classification of Impairment, Disabilities, and Handicaps, and it measures the level of a patient's disability, indicating how much assistance is required for the individual to carry out activities of daily living. It contains 18 items composed of 13 motor tasks and 5 cognitive tasks. And tasks are rated on a 7-point scale, ranging from total assistance to complete independence. The scores range from 18 at the lowest to 126 at the highest, indicating the total and overall level of function. And scores are generally rated at admission and discharge. The dimensions assessed include eating, grooming, bathing, upper body dressing, lower body dressing, toileting, bladder management, bowel management, bed-to-chair transfer, toilet transfer, shower transfer, locomotion, stairs, cognitive comprehension, expression, social interaction, problem solving, and memory. The ICF domain of the assessment is the activity, and the populations tested are brain injury, multiple sclerosis, older adults in geriatric care, Parkinson's disease, spinal injuries, stroke, and mixed populations. The age ranges being 18 to 64 and 65 plus, so essentially anybody over the age of 18. The equipment required is going to vary based on the level of impairment and the category measured. And the time to administer the assessment is 30 to 45 minutes, although as physical therapists, we would probably only be doing a couple components of this, and OT and speech would really be taking over the rest of it. But a special consideration of this is that it is not free. You need a license to use the FIM instrument, which can be obtained at udsmr.org. However, if you want to get around that, you are more than welcome to just do it without paying the cost and just accepting whatever legal ramifications ensue. So a brief description of the reliability and validity is going to mostly encompass stroke, spinal injury, and brain injury. For stroke, there is adequate to excellent validity with no reliability listed. With spinal injury, there is adequate to excellent validity. The inter-rater reliability is poor to excellent, and the intra-rater reliability is excellent. For brain injury, there is excellent validity and excellent inter-rater reliability. And for older adults in geriatric care, there is excellent test-retest reliability. There is a ceiling effect for spinal injury on communication and social cognition. And for as far as predictive qualities for stroke, individuals who scored less than 30 or who scored 37 to 72 on admission had greater gains than those who scored less than 37 or greater than 72. And as far as a limitation of the assessment, again, it does require a license to use from the company, and it is not free. So you should consider this when making your final decision. For the FIM instrument, we would just really be doing some components from the transfers in the locomotion. However, once again, you do need a license to administer this, and if you do decide to administer this without, you assume all of the legal ramifications that follow. With that being said, all right, miss, what I'd like you to do is I'd like you to sit up on the edge of the bed, please. And then let's see if you can transfer from this bed to this chair. Okay. All right, so she would get a completely independent score on that as she's fully functioning. All right, so next could I have you stand up, please? Okay, and what I'm gonna have you do, it says just to watch her walk. So she has a belt, she has a gait belt. For this, the purposes of this, I just want you to walk over to here. Okay, all right, very good. And now, normally you would also assess her doing this on stairs. As we do not have stairs, we have a little bit of a stoop right here. So we're gonna use that to sort of simulate some stairs. All right, I'd like you to walk these stairs right here. Excellent. All right, and we're gonna have her come down. Okay, again, she would get a 7 completely independent for that measure. Thank you so much.
The Fugel-Meyer Assessment of Motor Recovery After Stroke. This test evaluates and measures recovery in post-stroke hemiplegic patients, and it encompasses 5 domains covering pain, functional mobility, and ADLs. It is one of the most widely used quantitative measures of motor impairment and is commonly used in the clinic and research settings. It lies within the body function domain of the ICF model. The 2 populations it encounters are stroke patients, acute and chronic, as well as non-specific patient populations, which the research looked at MS and TBI. The cost is free to administer, but there is equipment, so the tennis ball, spherical container, reflex, test tool, space to move around freely that is quiet with few distractions. It takes about 30 minutes, but shortened versions have lasted less than 10 minutes. Ceiling effects with the test include the sensation subscore for acute stroke patients, and they've discovered floor effects for the modified balance domain for 14-day post-stroke participants. Concerning validity, there is excellent rating for acute stroke, which is 5 days post-stroke, resulting in the strongest predictor of motor recovery at 6 months, which is predictive potential. There is poor validity for sitting balance items, and another excellent rating for construct validity in acute stroke. Face validity is considered very good. Limitations to this test include the sensation, balance, and joint range of motion and pain subscores are less well suited for the test's purpose. The joint range of motion subscore is considered a confounding variable and deemed unnecessary. Finger movement really isn't assessed. An inclusion of subjective items reduces its reliability. Better balance measures are available currently, so it's suggested not to use it for balance. And the arm subscores are weighed heavily more over the leg subscores. Concerning reliability, there is 3 excellent ratings for chronic stroke patients, the non-specific patient population, which is including MS and TBI, as well as intra and inter reliability for acute stroke, which the researchers consider to be 0 to 6 months post-stroke.
We are going to be going through the Fugel-Meyer assessment on this patient, Holly. This is assessing post-motor skills after a stroke. So we are going to start with reflexes. So Holly, if you just let me have your left arm here. We're going to be starting with the upper extremity. And we'll do bicep. There we go. And then we'll do her tricep as well. Alright. And And then the scoring is on the sheet posted, but it's usually a 0, 1, 2, where 0 is they're not able to perform the task, and 2 is they can perform it. So now we're going to go into volitional movement with synergies, which just means voluntary movement and do they have synergies. So Holly, with your right hand on your right kneecap, can you bring it up to the other ear? Okay, and back down. And then we would check this bilaterally, but for the sake of time, we'll just show it on one side. And then also, so we went from here to here. Now I want you to start here, Holly, and then go back down. Great job. So now we're going to move into some more movement, but this is mixing synergies. So with your right arm, can you start on the knee, and then can you set it behind your low back like this? Great job. And then you can set it back here. And are you able to just lift your arm straight up in front of you, just right there? Great job. The next thing I want you to do is you're going to be here, and then you're going to turn your palm down, and then you're going to turn your palm right back up. Great job, no problems there. So now we're going to move to volitional movement with little or no synergy. So what I want you to do, Holly, is we're going to be lifting that arm out to the side, so straight up over your head. There you go, like that. Good job. And the next one we want to do is we want to start here where we ended in front of us, ourselves, and then we want to go as high as we can. Okay. And then the last one we want to do here is straight arm like this, and then we'll do the same thing where we turn the palm up and down. Very nice. So if she scored perfectly on this last section, these last 3 we did, we would retest the reflexes. Otherwise, we would continue on to the wrist. So that was all shoulder and elbow. Now we're going to the wrist. So what I want you to do with your, we'll just to the left, is can you just lift your hand up like that much or so? And then don't let me push it down. Just checking for stability here. And now can you do this? Repeat this motion. Good job. Okay? So what I want you to do now is with your arm straight, it's the same thing. Can you lift that hand just a little bit? And then don't let me push that down. Checking for stability again. And then now with the straight arm, can we do that same repeated action? Very nice. And also, the last thing I want to do here is, can you just do circles for the wrists? And then can we go the other way? Very nicely done. Let's go to the hand. So what I want you to do is, you're just relaxing your arm, is I want you to make a fist. Okay, and then can you go this much the other way? Yeah, there you go. And then we want to work on some grasps now. So we're going to do a hook grasp as if you're grabbing a briefcase. So all you're going to do with your hand is this. We'll go like that here, there you go. Okay? And then, so what I want you to do with this notebook is, with your thumb, just kind of pressing down onto your thumb. Okay? Hold on to it, don't want to pull it. Okay. Good job. With this water bottle, I want you to grab it like this. And don't let me take it. Good job. With this pencil, you're going to be kind of like a little pincer. You're just going to hold it, okay? There you go, yeah, we're just playing tug of war here. With this ball, I want you to hold it like this. Okay, and don't let me take that. Alright, so now that we've done that, we want to check some coordination. So we're going to go from your knee with your right hand up to your nose. And I want you to go 5 times, so your eyes need to be closed. And I want you to go as fast as you can. Okay? And now we want to check sensation. We're almost done here. So I want you to close your eyes, and then I'm going to press on a certain part of your arm. I want you to tell me when I'm pressing. Okay, so you're just checking 3 locations: upper arm, forearm, and the IP of the thumb. And now we're going to do just passive range of motion. So Holly, what I'm going to do is I'm going to move your shoulder. You don't have to work at all. You're just going to relax. So we'll check flexion. And then we'll come out to abduction. And then we'll check internal, external rotation. You can check it at 90 degrees of abduction or at the side. It doesn't really matter, it doesn't say. So then we'll go to the elbow. And I'm just going to see if we can bend it. And then straighten all the way out. And then we'll come to the wrist. And then can you bend it all the way up? And bend it all the way down. And then we'll check the fingers. Can they curl all the way in? And then can we pull it all? There we go. And so you'll add up all the scores for that, and then you will use the predictive scores that have been designated for this test, and that'll be all.
Alright guys, for the last outcome measure, we will be discussing the scale for controversive pushing, also known as the SCP. An SCP is administered in the stroke population. It is a 3-item scale that measures lateral pulsion, also known as pusher syndrome, by rating the action and reaction of patients required to keep or change position. The ICF domains of the assessment are body function and body structure. The SCP assessment is administered in 10 minutes. It has an excellent inter-rater reliability with a total score of 0.971 SCP and an excellent validity with a total score of 0.632 SCP. Currently, there are no special considerations reported. There are no ceiling or floor effects that should be considered reported. There are no predictive qualities reported, and there are no limitations of the assessments reported. Scale for controversial pushing. This assessment is basically looking at 3 variables: the spontaneous body posture, the use of the non-parodic extremities, particularly abduction and extension, and resistance to passive correction of tilted posture. So 0 is non-controversive pushing, 1 is a minimum score, 2 is a maximum score. So Matt is my patient here. I'm properly guarding him. Most of this assessment is based off of observation. So we're observing him in sitting, we're looking at his spontaneous body posture. If there was any severe controversive tilting with falling to that side, Matt would get a score of 1. If there was mild controversial tilting without falling, he would get a score of 0.25. And if there was severe controversial tilt without falling, it would be inconspicuous. So this is sitting, looking at his spontaneous body posture, and standing is next. So Matt, I'm going to have you carefully step off. And also remember the population. This is a stroke population, so go ahead and carefully step down, Matt. And properly guarding Matt, looking at the same 3 things in sitting and standing. Okay, Matt, I'm going to have you go ahead and sit back down for me. Okay, so next we're going to look for the use of the Forgetting our 3 variables, now we're looking at the second variable, the use of the non-parodic extremities. So once again, particularly abduction and extension, we're observing our patient. We have him close in proximity to make sure he's safe. We would give him a value of 1 if he performs spontaneous, already when at rest. We would give him a value of 0.5 performed only on changing the position, such as transferring from bed to a wheelchair. So sitting position, we'll look for this when you go ahead and from sitting to standing. So Matt, I'm going to have you go ahead and stand up for me. Standing, we're observing body posture and just assuring no extra sway. Okay, Matt, so I'm going to have you sit down so we can go ahead and observe the 3rd variable. So the 3rd variable is resistance to passive correction of tilted posture. With controversial pushing, we're going to correct Matt's posture. Okay, and so a value of 1 is if resistance occurred, which Matt gave resistance, so resistance occurred in sitting. A value of 0 is if resistance does not occur. So we'll go ahead and assess our patient in standing as well. Will you mind standing up for me, Matthew? For body resistance.